Abdominal pain in children. Differential diagnosis of abdominal pain in children. Luckily, most children with abdominal pain, the pain is mild with rapid improvement, and only few, 2% of episodes of acute abdominal pain require surgery. The most important step in making a diagnosis of abdominal pain in general in pediatrics is detailed history. Detailed history should be focused more based on the location of the pain, if the pain from the right upper quadrant or the left upper quadrant or right lower quadrant or left lower quadrant or epigastric. History is very important to make the diagnosis of pain in the right lower quadrant. For example, constipation. Ask about history of constipation in the past, difficulty with bowel movement, clogged bathrooms, taking too long in the bathroom to have bowel movement. Very important, very common cause, most common cause of abdominal pain in pediatrics. Mesenteric adenitis. Ask about gastroenteritis before, like vomiting or diarrhea. This can be associated with mesenteric adenitis. Similar will give you pain mimic appendicitis, but is not. Appendicitis, the pain is acute, usually associated with fever and continue to be worse. Doesn't get better until the appendix is removed. Intussusception. Ask about history of diarrhea, lethargy, the child is being fatigued and tired and vomiting. Very important not to wait for blood in stool. Ovarian torsion in a girl with sudden onset abdominal pain, sometimes comes and goes or persistent but doesn't resolve and get worse. Testicular pain, sudden abdominal pain in a child, always examine the testicles. Hernia, examine the child standing and laying down to explore for any hernia and ask about any bulging. Acute obstruction and perforation, ask about bilious vomiting. Epigastric pain, ask if the pain is meal related, like in cases of esophagitis or gastritis. Pancreatitis, the pain is always worse with meals. Volvulus, ask about bilious vomiting. History of headaches and taking pain medicine for a long time can cause epigastric pain and gastritis, like ibuprofen or non-steroidal anti-inflammatory drugs in general. Pain in the left upper quadrant, the source can be the spleen. Ask about trauma or history of a viral infection like EBV infection can cause pain in the splenic area. Left lower lobe pneumonia can be associated with left upper quadrant pain. Renal and UTI also can cause pain in this area. Left lower quadrant pain, constipation is very common cause of pain in this area. Colon also, if someone has colitis or any problem with the colon. Left ovarian torsion, the pain will be sudden. Testicular torsion, pain will be sudden. And hernia also, the child may have history of hernia or bulging in certain area above or in the testicle. Sigmoid volvulus, ask about bilious vomiting and sudden onset pain. Pain all over the abdomen. This can be associated with gastroenteritis, constipation, functional abdominal pain, abdominal migraine, cyclic vomiting, streptococcal pharyngitis, intussusception, inflammatory bowel disease, Henoch-Schönlein purpura, familial Mediterranean fever, diabetic ketoacidosis, and trauma. Most critical to be able to narrow the differential and to make your diagnosis, most important step is history, detailed history, and thorough physical examination. Differential diagnosis based on the color of the vomitus. If you have bile colored or bilious vomiting, persistent bilious vomiting is always serious, commonly associated with bowel obstruction and mid-gut volvulus. The vomitus is coffee ground color or bloody. What is the most likely cause? Can be associated with esophagitis, gastritis, gastric ulcer, or trauma from forceful vomiting. What about if the vomitus is bright red blood, large volume? This can be associated with esophageal tear, Mallory-Weiss tear, gastric ulcer, duodenal ulcer, and esophageal varices. Vomiting just the food or the gastric contents. The most common is infectious gastroenteritis. Rarely obstruction can do that. What about if the vomitus is fecal appearance? Usually obstruction. Differential diagnosis based on appearance of stool. Watery diarrhea. Most common cause of watery diarrhea is infectious gastroenteritis, especially viral. Can be caused by bacterial or parasitic. Very important to know that appendicitis with perirectal abscess or appendicitis in general can be associated with watery diarrhea, and this can be misleading and delay the diagnosis of acute appendicitis. How to differentiate from the history and physical examination the abdominal pain in case of viral gastroenteritis and acute appendicitis, and both of them they have diarrhea. In case of viral gastroenteritis, the pain will be getting better, not worsening, and the pain in general is mild to moderate, not severe. And also in physical examination, you may have more tenderness on the left side than the right side. In case of appendicitis, the pain will continue to be worse, not getting better, is out of proportion of viral gastroenteritis, and you will see the tenderness and guarding more on the right side than the left side. And the definitive diagnosis will be with abdominal ultrasound focused to the appendix. If the appendix is normal, you are dealing with viral gastroenteritis. If the diagnosis is not clear or the appendix is not seen, you have to order a CT scan focused to the appendix, and this will confirm the diagnosis. If the stool is hard and large in diameter and decrease in stool frequency, you are dealing with a case of constipation. Is very common. Once you know the diagnosis, you can manage and the pain will go away. But constipation can be severe enough to make you think of acute abdomen, and lack of history and lack of detailed history can delay the diagnosis. If the stool has a small volume of bright red blood, the most common fissures from constipation. Fissures from constipation. Hemorrhoids can do that because of constipation. Less common, Henoch line, purpura colitis, or polyps. Current jelly stool is a late presentation, is a blood in stool because of bowel ischemia, is a late presentation of missed cases of intussusception. Never wait for this presentation, is very late. Melena or black stool or tarry color stool associated with gastric ulcer, duodenal ulcer, because the digested blood will make the stool dark or black. Pale or ecolic stool, the stool looks clay color, commonly associated with biliary atresia or hepatic disease. Gastrointestinal investigations. CBC can assist in the diagnosis of certain conditions. For example, classic cases of acute appendicitis associated with leukocytosis or elevated white count more than 15,000. Chronic blood loss can be associated with anemia. However, it cannot be relied on to exclude serious illness. ESR and CRP, when they are elevated, they indicate inflammatory process, like cases of inflammatory bowel diseases. And normal ESR and CRP also cannot exclude serious illness. Don't miss urinalysis when you have a child with abdominal pain. If you do not analyze the urine, you will not know if the cause was UTI, for example. Also, urinalysis can show pyuria. Diabetes mellitus or diabetic ketoacidosis can be associated with abdominal pain. Cases of nephritis. Kidney stones can show hematuria. So very important to do urinalysis for any child with abdominal pain. This is the end. Thank you.
Having trouble or trying to pass the pediatric board exam? We have the definitive solution for you, presenting the Last Minute Review Series, a powerful tool for achieving success in pediatric board exams, crafted by Dr. Osama Naga, a board-certified pediatrician by American Board of Pediatrics and the editor of the Pediatric Board Study Guide, a last-minute review. Dr. Naga breaks down the most critical subjects in this series. The Pediatric Last Minute Review webpage offers a thorough and rigorous set of pediatric board review sessions that are in line with the study guide. The lectures will cover the most important topics for each condition that a pediatrician must know for pediatric board exams, as well as real-life clinical encounters. The inclusion of a clinical case scenario, accompanied by multiple choice questions, followed by the most probable answer and a comprehensive description of the issue, will ensure test readiness for each student. You will be able to download the lecture's PDF files to make your studies easier, to take notes and be accessible on the go and offline. Based on the membership plan you choose, you will have unlimited access to the lectures for either 1 month, 3 months, 6 months, or 1 year. By viewing these videos, you will increase your chances of passing the board exam and gain substantial advantages from the acquired knowledge. Additionally, By studying the material and completing the AAP prep questions from the previous 3 years, you will greatly increase your likelihood of passing the board and will acquire a wealth of knowledge. Click on the link provided below to visit lastminutepediatric.com and subscribe immediately. Be sure to take advantage of our free video samples on our YouTube channel, Pediatric Board Last Minute Review. Good luck with your exams.